Okay, lovely. So I do have some learning objectives for this talk. I know menopause is quite a sort of specialized field, but there are some sort of common clinical scenarios that you may come across, and it's nice to know what to say to patients. Mostly it will be sort of when you're sort of ST1 and 2, um, you will be involved with counseling of the patients more than anything else, more than prescribing HRT. So it's nice to know a little bit about what to say in each situation. The other thing I want to sort of signpost quite early on in the talk is that there's a slide right at the end which gives you sort of a snapshot of all the resources that are available to you. So especially when it comes to preparing for the Part 2 exam, but also if you come across a clinical case and you want a bit of expert advice, then that's a good slide to hold on to because it's got all of the sort of resources on one page. All right. The other thing I've done is I've put up a feedback link, a Survey Monkey link on the conversation box on Teams. So I'd be really grateful if you could fill that out. It takes about 3 minutes to do, and it's about sort of feedback about my talk. So that's available to you as well. So Bal, we can go into sort of clinical scenario number 1. So the next slide, please. So Mrs. Gwyneth Paltrow comes to you and she says, I'm a 46-year-old and I've been having really irregular cycles, often with heavy bleeding. And I'm also suffering from these terrible mood swings and hot flushes. I'm not really sure what's going on. And this can be quite a common situation to find yourself in. And it's to understand a little bit about menopause yourself before you explain it to patients. So the average age of menopause in the UK is 51. So at 46 to have these symptoms is not uncommon at all because menopause, though we say average age is 51, symptoms can start about 4 to 5 years before that stage. And it's sort of called a perimenopause stage where you can have symptoms as well as sort of irregular cycles. And different women have different ways of presenting. Some people will just have their periods stop. And that's the first they ever feel that they are in menopause. Whereas for some people, they can have years of like having symptoms before their cycles actually stop. Now, 1 in about 100 women experience premature ovarian failure, which is having menopause before the age of 40. And those are the women that we need to sort of investigate and treat, definitely treat. All right. And we'll talk about what tests we need to do in that age group. So the question is for Mrs. Gwyneth Paltrow, are we going to test or not? Bal, can we get to the next slide, please? Baljinder? Thank you. So if a woman presents and she's over 45 years, back, yeah, over 45 years, if she has got symptoms that are suggestive of menopause, with or without amenorrhea for 12 months, we don't really need a test. We just treat based on symptoms if that's what she wants. If she wants medication to manage her symptoms, then that we do. We don't need to test at all. But if somebody's under 40 years and she's had amenorrhea for 4 months at least, or she's got irregular cycles where the cycle length is very, very long, which is called oligomenorrhea, and she presents with typically vasomotor symptoms, then this is the age group in which we perform the test. And this table is taken from the NICE guidance. So you do 2 FSH tests 4 to 6 weeks apart, and the values need to be at least over 40 international units per mil. Now, the reason why we don't test for people over 45, part of it is economics, and part of it is the fact that the FSH levels fluctuate quite significantly. So testing actually is not very helpful. You know that when you're 45 or over, you're coming close to the menopause age, and symptoms are enough for us to sort of treat as if this person is perimenopausal or in menopause. Again, word of caution for testing in younger women: if they're on hormonal contraception, the tests are likely to be false. So we don't test if they're on estrogen and progesterone containing contraception. All right. Next slide, please. Now, I thought it's nice to sort of revise the physiology behind menopause, because sometimes you'll find patients want to know this information, and it's nice to know this because you can draw a quick sort of like diagram to explain. And especially in the part 2 exam, if a station comes on menopause, it's nice to be able to explain this in a schematic way to the patient in a short period of time. So the normal hypothalamo-pituitary ovarian axis is that there's GnRH secretion from the hypothalamus, which stimulates the pituitary to secrete FSH and LH in a pulsatile manner. And these act on the granulosa and theca cells, and there's a sort of like a really complex interaction between the two types of cells. And we've got estrogen, androgen, and inhibin production. Now, there is a negative feedback onto the anterior pituitary because of the estrogen and the inhibin. Now, what happens in menopause is that there is a depletion in the number of granulosa cells. So number of follicles sort of undergo attrition. And so the response to FSH and LH is very limited. And because of that, the negative feedback onto the anterior pituitary is lost. And so you've got very high levels of FSH and LH. Now, even though the granular cells have now undergone attrition, the stromal cells are still active, at least relatively active. So they continue to respond to this LH and FSH stimulation, and they produce androgens. So most of the estrogen that we get post-menopause is because of peripheral aromatization of these androgens to form estrone. All right. So even if women have undergone menopause, they can have estrogen circulate, a low level of estrogen circulating, which is why it's an argument to not take the ovaries out if you're doing a hysterectomy, if they're sort of close to 45 or 48, even if they've got menopausal symptoms, because there will be some background level of production of androgen, which gets converted to estrogen. This is the other reason why when you've got women who are overweight, who are obese, there is an increased risk of having endometrial cancer, because the aromatization happens because of the fatty tissue, because that's where it gets aromatized. And so you'll have more sort of conversion to estrogen, and there's an post-estrogen action on the uterus. So it's not sort of like related to menopause directly, but something to keep in mind. So is there any questions about this at this stage? Or am I going too fast? Well, no one's saying anything, so I'm just going to keep going. Yeah. Could we go to the next slide, please? Thank you. So this again is taken from the NICE guidance. This is what NICE advises we talk to patients about when they come with menopausal symptoms, and we're talking to them. We're sort of like introducing the concept of menopause to them. We've got to sort of briefly describe the stages of menopause, some of the common symptoms they may already be suffering, but others to look out for. What lifestyle changes could they implement that could help them make this transition smooth, as well as to safeguard them from long-term implications of menopause. Talk a little bit about the treatment that's available for the symptoms they're having, and again, talk about long-term health implications. Next slide, please, Val. So the stages of menopause, so it starts with perimenopause, which is about sort of 5 years before they undergo the final sort of like, they have their final period really, which is the menopause. And that's when they have a lot of the symptoms, like the vasomotor, hot flushes, night sweat sort of symptoms start around that period. Then obviously when they have their last period, which for some women may just be that they're menstruating normally and then suddenly it just stops and they don't have a period at all for like a year. But for some women leading up to this sort of last period, there can be irregular bleeding and quite heavy bleeding. And so that they may present with those symptoms itself. So up until then, it's called menopause. And then this menopause sort of transition lasts for a couple of years, and then it's called post-menopause, which is where they have to be safeguarded against sort of like the long-term implications of menopause. And we'll talk about that in the next slide. We have the next slide, please. All right. So this is talking about the short-term and the long-term symptoms of menopause. Now, the most common, so 75% of women suffer from the vasomotor symptoms, which is hot flushes and night sweats. And this is probably what bothers women the most. And this is what gets women to come seeking for treatment. So the reason we don't know exactly what the reason for hot flushes are, but it's thought to be because of the effect of the pulsatile LH on the temperature regulation mechanism. As we know, the genital tract responds to estrogen and progesterone as well. So you get the next most common symptom is urogenital symptoms. So you've got vaginal atrophy. And if they are at sort of risk of prolapse, this is when the prolapse symptoms may manifest as well, because the support to the uterus and the tissues is lost. The estrogen and progesterone support is lost, and we could have prolapse symptoms. And this leads to urinary incontinence as well. People have reported mood changes, so they can have sort of sudden mood fluctuations, but also suffer from low mood, which is different to having sort of a mental health disorder like depression. This is low mood that's associated with menopause, and it can be quite challenging to treat. Then they'd have sort of non-specific musculoskeletal symptoms like muscle pain, could have difficulty sleeping at night, and also sexual difficulties, which can be sort of twofold. One can be because of dyspareunia, because of the vaginal atrophy and vaginal dryness, but also can be because of the loss of libido. Long-term effects is osteoporosis, and the reason why you get osteoporosis is because estrogen sort of down-regulates the osteoclasts in the bone, and without the estrogen, the osteoclast activity is not down-regulated, and so you could have osteoporosis. Increased risk of cardiovascular disease. So the risk becomes equal to men. So before menopause, the risk of women having cardiovascular disease is lower than men, but after menopause, it becomes equal. And the reason is that estrogen reduces your LDL cholesterol and increases the HDL cholesterol, and without estrogen, sort of this effect is lost. Also, long term, you could have problems like dementia that is associated with menopause. Next slide, please. Now, some of the lifestyle changes we'd ask them to do is exercise. Now, exercise helps lose weight, which is important to sort of make sure that they're not, excessively converting androgens to estrogen, and what I spoke about earlier about the unopposed action of estrogen. It also helps improve bone strength. So they need to do a bit of weight-bearing exercises, because over time that will help reduce the risk of osteoporosis. Because this is a time of stress for most women, it's good to sort of include yoga and stress-reducing exercises as well, and meditation. Sleep hygiene, because lots of women can have insomnia, so to have like good sleep habits about like having a regular bedtime, using less devices before going to bed, that sort of stuff. Pelvic floor exercises, well, that's something that women should be doing from the time they have childbirth, but it's to reduce the risk of urinary incontinence. And you'd ask women to go on calcium and vitamin D supplements as well, and increase water intake to reduce bloating. Next slide, please. Now, not everybody requires treatment, and the aim of the treatment should be symptom relief. And so the treatment should be only taken as far as is required to get symptom relief. And also we need to keep in mind the medical history of the patient. So we need to take a proper history, take the blood pressure, BMI, all of that needs to be documented before we explore HRT. Now the options available are, the mainstream, which is hormone replacement therapy, but there are also non-hormonal as well as non-pharmaceutical options available. And some of which may be more important to a patient, especially if they've got a medical history which makes hormone replacement therapy not suitable. Could we go to the next slide, please? Right. So the most common symptom, as we discussed, is vasomotor symptoms, which is hot flashes as well as night sweats. Affects 70 to 75% of women, of which 20% can be severe and quite debilitating. It lasts for about 5 years. And so women may come for treatment for that. Now, the HRT is very effective for this particular symptom. So giving estrogen with or without progesterone. So you'd consider estrogen for everyone because that's the one that actually helps reduce hot flushes. Now, this is not the same estrogen that we use for combined oral contraceptive pills. This is sort of similar to the natural estrogen that's produced by the body. So you could either give it orally or transdermally. Orally, it's micronized estradiol or estriol or conjugated equine estrogens. Transdermally as well, it's 17-beta estradiol. Now, the difference between oral and transdermal has actually got less side effects than oral. But economics-wise, transdermal costs a lot more. So therefore, if they don't have any reason why they are at the high-risk group, we would go with the oral preparations first. Now, whether or not you'd consider giving them progesterone will depend on whether or not they have a uterus. Women who have got a uterus need to have progesterone because we can't give unopposed estrogen. It increases the risk of having endometrial cancer. And so the progesterone can either be given as cyclical oral tablets, or the other way to do it is to put a Mirena coil in the uterus. And Mirena, though it's been licensed for 5 years of use for contraception, the license that the company has got for HRT is 4 years, and that you need to keep that in mind. So they need to have the coil changed if they're happy with it in 4 years' time. If they don't want to have HRT, then they can have an SSRI, which is like citalopram, or an SNRI like venlafaxine, or clonidine, which is centrally acting alpha agonist antihypertensive. Now, all of these are not first-line treatment because they're not that effective against hot flashes, and giving HRT is more effective. But if obviously it was not suitable or they didn't want it, then these are options as well. Also, there are non-pharmaceutical over-the-counter medication that women may want to try. But there is no sort of RCTs to prove safety profile, or it could have, like St. John Watts has got a lot of drug interactions, especially with antidepressants and things like that. So to keep that in mind as well. Now, if we were to start HRT, so say like the woman wants to go ahead and have a combined oral, HRT, in which case, when you start it at the least, so the smallest dose that you can possibly start, and bring them back for a 3-month follow-up, because at that follow-up, you want to know whether the dose that you've started is effective or not, because you could increase the dose if it's not effective. But equally, you also want to know what sort of bleeding pattern they've had. So you can, when you start HRT, you can inform the women they will have some irregular bleeding in the first 3 months. But this is not something that will persist after the 3-month mark. So they need to be aware that if it does persist, they need to let you know because you need to evaluate the endometrium. Now, at 3 months, if they're quite happy with the dose that you've started them on and their symptoms are under control, then they can be put onto an annual follow-up. And obviously, they'll need to come in at any point if they've got bleeding. All right. The next symptom is psychological symptoms, a low mood, but not quite depression, but it's not quite depression. It's associated with menopause. And we don't have any evidence to say the SSRI or the SNRIs work for this in this scenario, but it's worth giving it a try. Again, you can consider HRT or CBT, depending on how far the woman wants to take this. The other complaint that's commonly seen in the menopause clinics is reduced libido. And the first line would be to start them on combined HRT or estrogen-only HRT, depending on if they have a uterus or not, and give them a trial for 3 to 6 months to see if that helps. And if that doesn't help, you could consider adding on some testosterone. It's not very well studied, but there is some evidence to suggest that it can increase libido. And again, you start it at a very low dose, and it's like a twice weekly use, and you bring them back in 3 months to see if it's made any difference at all. One of the conditions that likely you will be asked to prescribe medication for is vaginal atrophy, because you could come across this symptom in any clinical scenario. You could be in theatre on a urogynecology list, for instance, and vaginal estrogens are prescribed routinely in that condition. And also the other reason why vaginal estrogen is used very commonly is because the bioabsorption of vaginal estrogen is very low. So even if you've got contraindications for use of oral estrogen, you could still consider using a vaginal estrogen. If that is absolutely contraindicated, then there are a lot of water-based and oil-based lubricants that can be advised to help with sexual intercourse. What I've not put on the slide is a medication called Tibolone. It's sort of it's an oral synthetic steroid which has got estrogenic, androgenic, and progesterogenic properties. It's used a lot when you give somebody GnRH sort of antagonist or agonist for treating them for, say, fibroid uterus, and you want to continue that treatment for a while. Then you give it as add-back therapy. It's less commonly used in a menopause setting, but it is an option that's available. Next slide, please. What I wanted to briefly discuss were some of the landmark sort of trials that have been done in the field of menopause, based on which a lot of the sort of recommendations have come about. This is sort of like just for historic interest more than it, you needing to really know this. So the first trial that was done in 1970 was the heart and estrogen progesterone replacement trial called HERS-1 and 2. The trial was started because they wanted to find out what helped women have a less risk for cardiovascular disease than men. And they thought that it might be estrogen. So they wanted to see if estrogen replacement continues to sort of benefit. Now, when they recruited for this trial, it was a randomized control trial, and they recruited women who were average age of 66, which is quite a few years after menopause. And this trial didn't show there was any benefit at all for cardiovascular risk from HRT, but it showed that there was an increase in venous thromboembolism as well as gallbladder disease. After this trial was done, there was a women's health initiative because based on the feedback from the first trial, they thought, okay, maybe we shouldn't be taking women who are so well into menopause. We should be taking healthy, sort of more immediate postmenopausal women. This again was a randomized control trial. And they had one arm who was on, so they had three arms to the trial. One was the control arm. There was one arm that was on combined estrogen and progesterone, and then another arm that was only on estrogen. They had to prematurely stop the combined arm because the risk for breast cancer, stroke, and VTE was unacceptable. But they found that the estrogen-only arm, which continued, the trial continued with the estrogen-only arm, they found that there was a benefit. And this led to a very important sort of finding, which is that there's a window of opportunity to start HRT. So it's recommended that you don't start HRT if you're 10 years post-menopause because the risks outweigh the benefits. So best is to start HRT within sort of like an immediate postmenopausal state where the symptoms need sort of managing, but not to continue it for sort of more than 5-6 years, right? Then the Million Women study came about, which recruited women of people who are having breast screening to study the risk of HRT and breast cancer. And it found that there's an increased risk of breast cancer with HRT. And we'll go over exactly what that increased risk is in a couple of slides. But the Million Women study was criticized because what they did is they did not discount people who already had breast cancer. And also people who come for screening for breast cancer may already be at increased risk of breast cancer. This was not like general population. So essentially it was criticized after the trial was done. And then the most sort of like Cochrane released a 2012 systematic review, which showed that HRT does reduce the risk of bone fractures, but there's no indication to start the HRT for this reason alone. And there's no indication to start HRT to prevent long-term sort of risks of menopause. So HRT is indicated only for short-term sort of symptoms and for symptom management. Next slide, please. Now, when discussing risks of HRT with women, there are a lot of like papers you could quote, which all sort of have different numbers that they sort of throw up. But I thought this slide this table from one of the TOG articles sort of nicely condenses everything and makes it easy to counsel, because even though the numbers may be different in different studies, this table tells you where the risk is reduced and where it's increased. So the risk for HRT, risk or benefit for HRT is discussed in as 1,000 women for 5 years of HRT use. And the risk is divided. The risk is divided as estrogen only or estrogen and progesterone. And so you can see that in sort of like whether it is estrogen and progesterone or estrogen only, it reduces your cardiovascular risk, it reduces the fracture risk. Estrogen and progesterone, so the progesterone component especially increases the breast cancer risk. Stroke risk is increased if you use HRT, and so is the thromboembolism risk. So this is I thought this is quite a nice snapshot to give you an idea of how to discuss that. Now in Oxford, in the menopause clinic there, they quote the Lancet paper, which came out in 2019. And they specifically quote that there are 10 cases of breast cancer in every 1,000 women for using HRT for 5 years, and an additional 25 if you use HRT for 10 years. So it's just slightly different to this table, but I think it sort of says the same thing, which is that you increase your risk of breast cancer if you're using both estrogen and progesterone. And then Cancer Research UK has a sort of infographic as well that you could use to describe, because it puts it into context, because these women would already have a background risk. So whatever you're doing, it increases it over the background risk or reduces it below the background risk, but they can do other things to reduce the risk, like stop smoking, lose weight, that sort of thing. All right, next slide, please. Val? Yeah. So this is from one of the TOG articles. And this, I thought, like, rather than discussing it in detail, I just wanted to tell you there are a lot of regimes that you could use, and each unit will have their own sort of way of dealing with it. But this is a nice guidance of what to start in which situation. And you can sort of have a read of the TOG article as well, because it goes into that in more detail. Can we go to the next clinical scenario, please? Yeah. So Angelina Jolie comes and she says, I'm 37 years old, I'm BRCA1 positive. I want to have risk reduction surgery, but I want to know what my options are because I'll go into menopause straight away. And so this is again a really common scenario, because you'll do a lot of elective gynae operating, and where you will see women who will come for risk reduction surgery. And it's important to know what you're going to have to tell them about what your options are. If you can go to the next slide, please. So we need to discuss again the effects of having risk reduction surgery. So unlike natural menopause, which occurs over multiple years, having risk reduction surgery where they remove the ovaries, sometimes they don't remove their uterus. It depends on what type of mutation they've got. Most likely they remove just the ovaries. The effect of menopause is sudden. So the symptoms that they experience can be quite sort of like drastic and exaggerated and quite sudden. So whilst you keep that in mind, you also have to discuss what the long-term effects are for menopause. And most of the women undergoing risk reduction surgery are less than 50 years old. So they would, under normal circumstances, have been exposed to estrogen and progesterone till about 50 anyway. So the Scottish guidelines on sort of ovarian cancer recommend that you start HRT for women undergoing risk reduction surgery up until the natural age of menopause, which is about 50 years. Because there is no sort of, because you put them on menopause, there's no decrease in the benefit of having the surgery. So it's safe for us to start them on HRT. And again, depending on the surgery they have, whether the uterus is removed or not, you'll base that on whether they're going to have progesterone or estrogen or only, or estrogen and progesterone combined. Again, when discussing the surgery, it's important to sort of find out what type of mutation they have and what their risk of breast cancer is with that mutation, because one of the things that should be included in the discussion is whether they remove the uterus or not. And that can make HRT easier if the uterus is removed, because as we've just discussed, progesterone is the one that increases your risk of breast cancer the most. So removing the uterus then will allow you to give estrogen only HRT and may, sort of help balance the risk of breast cancer. But that's a discussion that needs to happen between the consultant and the patient and the breast specialist about what would be the most appropriate surgery for them. BRCA1 generally tends to be ER/PR negative and BRCA2 ER/PR positive. Again, something to be kept in mind when you're considering HRT. And like we just discussed, it needs to be shared decision making, and also to discuss at that time what non-hormonal options they've got if they are absolutely not keen to have HRT. The reason why we give them HRT is because you want to, reduce the risk of them having the long-term effects quite early, especially because till 50 you'd expect them to have, 50 is a natural age of menopause, so you want to continue HRT till then. So you want to have a thorough discussion about what it would mean if they chose not to go on HRT. And then we talk about osteoporosis screening and prevention. So they need to have routine DEXA scans, and also vitamin D and calcium. And even if they chose not to go on oral or transdermal HRT, they could have local estrogen use to help prevent vaginal atrophy and sexual dysfunction. Next slide, please. So we've got, so she's 52 years old and she's got terrible hot flashes, and she would like some HRT. She would like to discuss HRT, but unfortunately she had breast cancer 5 years ago, and so she wants to know what her options are. Next slide, please. So for Kylie Minogue, unfortunately, because of the history of breast cancer, there are not very many hormone replacement options that are available. And if she was continued to be on tamoxifen, unfortunately, SSRI and SNRI is not recommended either. So what would be best is to refer her to a specialist clinic, because they would have access to sort of the breast cancer specialist as well, to have like a multidisciplinary team like plan, depending on how bad the symptoms of menopause are. Again, all of the non-pharmaceutical options are not good either, because somebody with a history of breast cancer may be on medication, which could interact with the non-sort of pharmaceutical options. So the options are limited, and it's to sort of have a specialized discussion on to balance the risk versus benefit in the situation. Next slide, please. Now, Addison Shepherd says that her period stopped when she was 36 years old, and what medication should she be on. Now, this situation is very similar to somebody who's undergoing a risk reduction operation. Essentially, you want to start them on hormone replacement till the natural age of menopause, which would be about 50. But what's important to keep in mind is people who undergo premature ovarian failure are still at risk of getting pregnant. Could we go to the next slide, please? So they're still at risk of getting pregnant. There's about a 5% risk of conceiving even after premature ovarian failure. And so whilst we offer them hormone replacement therapy, we need to inform them that it's not a contraceptive because the doses are too low. And so if they wanted to absolutely avoid pregnancy, then rather than putting them on the hormone replacement therapy, we would offer them combined oral contraceptive pill, because that would do both the job of providing hormone replacement as well as acting as a contraceptive. It does not, neither the oral contraceptive pill nor the hormone replacement therapy will increase the risk of breast or cardiovascular disease. Oh, thank you. Will increase the risk of cardiovascular disease till like the natural age of menopause. So it's safe to start. And it will also offer bone protection, which is important. So this is what we would counsel them about. But if somebody gets diagnosed with premature ovarian insufficiency, they do need to be seen by a specialist, because there may be genetic testing that needs to be done to find out why they've got premature ovarian insufficiency. So, but that's sort of a pathway that they will have gone through to get that diagnosis anyway. Next slide, please. So I thought we would sort of quickly discuss contraception and menopause, because one of the questions women could have is, when do we stop the contraception? So they've got like symptoms of menopause, but they're not sure if they should stop the contraception or remove their coil or whatever the question may be. So if they're more than 50 years old, and this is from the Faculty of Sexual and Reproductive Health, it's from their website that I got this information from. So if they're more than 50 years old, you stop after 1 year of amenorrhea. Stop the contraception after 1 year of amenorrhea, because the risk of pregnancy is very low after that. If they're less than 50 years old, then you stop up to 2 years of amenorrhea. Again, to sort of reiterate what we've already discussed, that HRT is not a contraceptive, because it is too low a dose and it doesn't inhibit ovulation in sort of 60% of the women. And contraception must be used along with HRT if you want to avoid pregnancy. So one of the good ways to do this is to put a Mirena coil in, because it can act as a contraceptive as well as act as the progesterone sort of component of HRT, and then just give either oral or transdermal estrogen. Next slide, please. And this is what I wanted to sort of, what I signposted you to in the beginning, which is all of the sort of resources available. So the British Menopause Society is the society that comes up with the guidelines for menopause in sort of coordination with NICE. There is a STRAT-OG module, which is free for all of us trainees, that can give you sort of basic sort of information about menopause, and it also helps sort of sign off things on the logbook if you finish that, because you get a certificate. The Lancet has quite a few papers that have been recently published on menopause. My Menopause Doctor is a website that we signpost patients to in Oxford. So if you do come across somebody you're talking to about menopause, then that's a good website to sort of point them out to sort of give them to look at. TOG again has a couple of articles and has sort of like examples of treatment regimes that we could follow. And these are the names of the people, of the consultants in this deanery who are menopause specialists. Dr. Katie Barber is a specialist GP at Oxford who runs the menopause clinic there. Ms. Jane Moore oversees that clinic. Ms. Sucheta Iyengar is at Stoke, who runs a menopause clinic at Stoke. Mr. Swanton at Royal Berkshire looks after especially the premature ovarian failure women, because he's a fertility specialist. So he's quite a good source if you wanted to sort of talk to him about research projects or a challenging case. Mr. Patrick Bose runs a private menopause clinic at Harley Street. So he has a menopause interest as well, even though he's an obstetrician at Royal Berkshire Hospital. Last slide, please. Thank you so much for listening. I hope it was not too quick, and I hope it made some sense. I'm happy to take questions. If I don't know the answer, I'll look it up and I'll get back to you. But also, could you please fill out the feedback? The link is in the discussion chat box. If you can't find it, I'll send it again. Any questions?
Hi, Aditi. I'm Josh. I'm one of the ST1s. I was just wondering that obviously there's a lot of information about what risks for various conditions are increased or decreased by taking or not taking HRT. Is there any research on the